During a routine local anesthetic injection, the sudden, aggressive expansion of a dark red mass beneath the tissue signals an immediate clinical emergency. We are looking at a hematoma. This is a localized collection of blood rapidly extravasating outside the vessel walls to form a semi-solid mass. It is a distinct, palpable swelling, completely different from a diffuse superficial bruise. Because dental injections typically happen in the highly aesthetic and sensitive areas of the face, the visual impact is dramatic. An expanding facial swelling creates a high anxiety crisis for the patient while in the chair. Almost universally, this clinical complication is iatrogenic. The practitioner's technique drives the needle through the vessel wall, meaning the trauma is largely preventable. Treating a rapidly forming hematoma as a minor nuisance ignores the reality of the situation. It inflicts acute pain, significant postoperative trismus, and lasting aesthetic trauma on the patient. Standard dental training often relies on a set of passive protocols to avoid these vascular breaches, primarily the use of narrow-gauge needles and the practice of aspirating in two planes. The prevailing assumption is that a smaller 30-gauge needle will cause less trauma to a vessel than a 25-gauge needle. In reality, a tear is a tear. The physical damage to the vessel wall is identical. Practitioners are also taught to aspirate, rotate the syringe 90 degrees, and aspirate again. While necessary, treating this two-plane check as an absolute shield provides a false sense of security during a deep nerve block. True prevention relies on the no-see standard. Instead of poking blindly to avoid blood, the practitioner must mentally map the target nerve and the accompanying neurovascular bundle in 3 dimensions to avoid the vessel entirely. Aspiration is not a preventative measure. By the time you see blood in the carpule, the anatomical approach has already failed. A hematoma occurs when a needle bevel slices through the wall of a high-pressure artery or a delicate, valveless vein. This animated diagram models the fluid dynamics inside a 25-gauge and 30-gauge needle under identical negative pressure. Because of the smaller lumen, the narrower tube draws up fluid significantly slower, meaning a thin needle actually delays your positive aspiration feedback. The mechanics of a false negative are straightforward. As you pull back on the plunger, the suction force pulls the pliable inner wall of the blood vessel directly against the angled bevel of the needle, sealing the opening completely. A quick snap of the thumb fails to generate the continuous negative pressure required to dislodge that tissue. To overcome the vessel wall block, aspiration must be slow and sustained. The gold standard protocol requires pulling back on the plunger for at least 5 seconds, rotating and repeating. The physics of fluid dynamics dictate that quick aspirations and small needles create a dangerous illusion of safety. We can view the injection as a vector and the specific blood vessel as the potential victim. This 3-dimensional map of the skull highlights the precise anatomical intersections where routine injection vectors cross high-risk vascular zones, like the pterygoid venous plexus and the inferior alveolar vessels. During a posterior superior alveolar, or PSA block, the needle is directed posterior to the maxilla. This specific trajectory passes dangerously close to the pterygoid plexus, a dense, valveless network of veins, and the maxillary artery. Striking this plexus results in a highly visible PSA hematola. Within seconds, a massive, soft swelling develops rapidly on the lower half of the face, lateral to the maxillary tuberosity. Shifting to the medial mandible, the inferior alveolar nerve block requires driving the needle vector deep into the pterygomandibular space, directly intersecting the inferior alveolar artery and vein. Because this hematoma forms deep within tight facial compartments, it is rarely visible externally. Instead, the expanding blood volume causes severe internal medial swelling and immediate lockjaw or trismus. Knowing the location of the target nerve is insufficient. You must actively map the surrounding vascular risk zones to plot a safe path. This profile diagram demonstrates strict depth control, a primary mechanical defense against vessel tears. By adhering to a strict 16 mm penetration limit for a PSA block, the needle vector avoids the pterygoid plexus entirely. Inserting the needle deep beyond the targeted neurovascular bundle is the overwhelming cause of catastrophic pterygoid plexus hematomas. To further protect the vessels, you can employ hydraulic buffering. As you advance the needle, you continuously deposit drops of local anesthetic ahead of the sharp bevel. The high-pressure fluid wave physically displaces delicate vascular structures, pushing smaller arterioles and venules out of the needle's path to create a mechanical safety buffer. If the needle incorrectly scrapes against bone during this process, it creates a microscopic barb on the tip. You must withdraw it completely. Redirecting a barbed needle while deep in tissue will tear any vessel it touches. Combining active spatial control with proactive fluid dynamics ensures the sharp bevel never touches a vessel wall in the first place. If a vessel is breached, you must immediately differentiate between a near miss, indicated by a positive aspiration of blood in the carpule, and an active bleeding event, marked by sudden, non-painful swelling. This clinical flowchart outlines the non-negotiable emergency response to an active hematoma, the stop and pressure protocol. The moment swelling is detected, you halt the injection, withdraw the needle, and apply bidigital pressure. You must not wipe or massage the tissue. Any rubbing action will disrupt early clot formation and accelerate the spread of blood through the tissue spaces. Instead, apply firm pressure between your thumb and index finger against the underlying bone. You must maintain this mechanical tamponade, strictly timed by the clock, for a minimum of 3 to 5 minutes. For high-risk patients on direct oral anticoagulants or dual antiplatelet therapy, the risk of massive internal bleeding escalates. They require up to 15 minutes of sustained pressure and a strict no multiple poke rule during injections. Mechanical tamponade outranks any other intervention. Timed direct pressure is the only definitive way to arrest the internal bleed. Once the bleeding is arrested, post-operative management dictates the application of extraoral cold packs for the first 24 hours to induce vasoconstriction. The application of heat is strictly prohibited, as it will cause vasodilation and restart the hemorrhage. This 14-day timeline tracks the clot's biochemical breakdown. The tissue shifts from the red-purple of deoxyhemoglobin to the green of biliverdin, then yellowish bilirubin. During days 3 to 5, the clot's mass occupies tight compartments, causing severe muscle spasm, pain, and restricted jaw movement. A stagnant collection of blood provides an ideal culture medium for bacteria. If a patient presents days later with a fever and throbbing pain, the hematoma has likely evolved into a secondary infection, requiring aggressive antibiotic intervention. If a large hematoma is left completely unresolved, the clot can organize. Fibroblasts invade the mass, resulting in permanent fibrosis or even bone formation within the muscle, known as myositis ossificans. A hematoma is a clear anatomical error. Mastering the shift from passive aspiration to proactive spatial avoidance and executing immediate, timed pressure when a breach occurs defines the gap between routine practice and precise clinical competence.